Good evening. This is a very useful presentation on everyday medical practice, and we all have prior knowledge substantially about its diagnosis and its management. But because we all follow differing guidelines, it is important to know what the current peer practice is, and therefore it's important to know how best to deal with this situation. So here we go with regards to checking up and seeing whether we have a PowerPoint slide with which we can actually see what we are going to talk about. So my picture has become miniaturized, which is of a less important concern, but reflux esophagitis, acid reflux, gastro-oesophageal reflux disease are all nearly the same things. And because of innovative medication, we now have various differing ways of managing patients' symptoms and how we follow this up as well. So initially, we're going to discuss about esophagus. And in this respect, we'll need to know exactly how it has developed, what layers it has, how it differs from stomach, and above all, because it's a condition where the stomach contents are regurgitated back. Therefore, we'll need to know what the role of the stomach is by way of its connection with esophagus, and of course, the clearance of its contents towards the small intestine for digestive, absorptive, and for many other gastrointestinal conditions and for normality of functions. This system has evolved over millennium, and therefore some mammals tend to regurgitate habitually, redigesting food which they have pre-digested earlier on. So we're going to talk about such basics of esophagus, how it is all interlinked with the basics of stomach, and then of course the mechanism of reflux and what symptoms it produces from the endoderm, and therefore it's a straight tube which is called esophagus, and it is composed of the usual 4 layers which most endodermal structures have, such as an outermost serosa, a muscularis mucosa, layers of muscles, and then obviously submucosa, and finally the mucosa. So the relevant aspect to remember is that it has only 2 layers of muscles, longitudinal throughout the length of the esophagus, as well as circular in the region where valvular mechanisms exist. Originally, as it develops, it does have a mucosa lined with columnar epithelium, as is the stomach. But then subsequently, towards 17 weeks, this mucosa changes to stratified squamous one for protective reasons. Only the last 4 centimeters of the esophagus, which is intraperitoneal, will be lined by columnar epithelium. So as far as esophagus is concerned, it's a 23 to 25 centimeter long tube, which begins from the upper esophageal sphincter and ends at the cardia, which is the lower esophageal sphincter. But when one does endoscopy, it's about 40 centimeters from the incisor tooth when the cardia is encountered. It comprises 3 parts. The first part is the cervical esophagus, which begins at the lower level of the cricoid cartilage from a combination of cricopharyngeus muscles and related muscles as well, which forms a bulbous container linked to the pharynx. And then it lies behind the trachea, and the nearby relevant organs are the thoracic duct on the left side and the carotids, and as well as the cervical spine, which is 6, 7, and 8, there is thyroid closely applied as well. The thoracic esophagus lies between the vertebral column and the trachea in the superior mediastinum, and it starts from the supraesternal or the jugular notch of the neck right to where the diaphragm is pierced behind the aortic arch, and then it enters the posterior mediastinum. Abdominal esophagus is situated from the right crus of the diaphragm, which the esophagus penetrates at the level of T10 into the cardia of the stomach, which is at T11. And this is where the fundus of the stomach also begins from. You would have noticed that the English version of esophagus is called esophagus with an O, and the European and the American version starts with an E. So, what is the upper esophageal sphincter? Obviously, this is where there is a combination of cricopharyngeus, thyropharyngeus, and cricoid cartilage. The entire purpose of the upper esophageal sphincter is to make sure that the food travels in the downward directions towards the stomach, and that at no posture would there be respiratory aspiration, which would be disastrous. So once the upper esophageal sphincter is allowed to relax, then it initiates the esophageal peristalsis. The first of it is the neurological mechanism. And then, of course, subsequently, it's the distension of the food bolus, which stretches the muscular walls of the esophagus, which further carries on the phase of peristalsis, in a sense that where it is distended, the subsequent part relaxes and the first part remains tight. So therefore, the bolus is propelled downstream. We'll talk about the innervation and the control in relation to subsequent matters. The lower esophageal sphincter, or cardia, is also a sphincter established by the concentration of the circular muscle fibers. And that the reason it opens up in a valvular mechanism, allowing bolus of the food to pass from esophagus to the stomach, is because the fibers, neurological control, which allows tightness of the sphincter, relaxes. So therefore, the lower esophageal sphincter opens up because of the relaxation of the sphincter. There is no innervation which actively dilates it. So the mechanism of continuing tightness relates to, and also relaxation relates to, bilateral vagal innervation, which is different on either side. And we'll talk about this in respect of medication. The submucosa is rich with the neurological mechanisms and the vascular mechanisms. The mucosa throughout in the pre-peritoneal part is composed of a stratified squamous epithelium, but from cardia downwards, it becomes columnar. So the interaction is sensitive. And this is how the histological mechanism should persist in relation to normality. Remember that even though the lower esophageal sphincter is constantly under tension and remains tight, there are a few physiological reasons when there is transient relaxation of the lower esophageal sphincter. And this is necessary when you think about a baby suckling or bottle feeding and is therefore needing to wind. Similarly, people who overeat or eat rapidly or eat an inappropriate combination of food will require to belch. And if there was no belching mechanism, then the distension would cause significant problems. So the relaxation of the lower esophageal sphincter is mainly physiological and is logically present so that the food transits in a one-way direction. However, there may be physiological needs for it to relax as well through a loop phenomenon. As we talk along the gastro-oesophageal reflux disease, one of the principal symptoms it is producing, which makes it recognizable easily, is dysphagia. So dysphagia is a condition where there is difficulty or inappropriate swallowing. And so this is actually the symptom of abnormalities of the lower esophageal sphincter. And if there is such a problem, then the weak part of the esophageal system, which is in the back of the cervical esophagus, there would be bulge, increased pressure, because there is volume loading, distension, but no transit. And this begins the early development of Zenker's diverticulum. But dysphagia could also be caused by abnormalities of motor innervation or due to objective obstruction. So the motor dysphagia occurs when the lower esophageal sphincter refuses to relax and remains under a constant state of spasm and tightness, or a larger segment of the esophagus, which is distended by the bonus distension, refuses to relax, and therefore there will be difficulties of propelling the food through peristaltic mechanism. Sometimes recurrent symptoms of dysphagia and GORD lead to fibrosis. There are some autoimmune disorders such as scleroderma, or when there is denervation or neuropathy caused by scattered untreated diabetes, which will cause motor regulatory disorders leading to the motor dysfunction causing dysphagia. On some occasions, there is development of an obstructive lesion, such as esophageal carcinoma, when there is abundant inflammation of the mucosa from regurgitation or reflux, which is esophagitis, when the intraperitoneal part of the esophagus develops an ulcer or a narrowing causing peptic stricture, or even when sometimes the abundant mucosa of the intraperitoneal part of the esophagus throws in such a large number of mucosal folds that they cause a mechanical obstruction. So what are the risk factors producing the symptoms of dysphagia and therefore also contributing to GORD? So these are obesity, sometimes there is genetic involvement, pregnancy enlargement, hiatus hernia, and then there are lifestyle triggers such as smoking, such as alcohol, caffeine, and frequent uncontrolled use of non-steroidal anti-inflammatory diseases, such as for joint pains. However, this relationship has hotly been debated not so long ago. So we come back again that the primary objective of this discussion is to talk about reflux esophagitis. And I have already explained that in order to understand that, we need to know about stomach secretions which regurgitate and why stomach secretions sometimes increase and sometimes decrease, causing GORD and also related diseases such as pernicious anemia and other problems. So we'll need to know about stomach. So we mentioned at the outset that at the earliest, at about 4 weeks, the foregut expands to form the primitive stomach. And then, as you would appreciate, that the cervicocaudal flexion occurs in the developing young fetus, and therefore the stomach is pulled down from the cervical to the lower thoracic region. This stretches the esophagus as a tube, and the disproportionate rate of growth leads to a typical J-shaped organ. So what happens is that a straight tube with a forward cervicocaudal bulge now turns towards the right side. And as it turns towards the outside, there is the development of lesser curvature on the right side, greater curvature on the left side. And so what has been present on the left side of the stomach, such as the left vagus nerve, now becomes anterior vagus. And this is why the vagus nerve initially on the right side of the esophagus now becomes posterior vagus. The vagus produces direct innervation control about when to relax the circular muscle fibers. But it also has, in the submucous part of it, automated myenteric plexus of our back, which means the more the stomach distends, the more it will try and recoil back. And the other nerve plexus is submucosal plexus of Meissner. They're both linked through a system with the spine. And so the vagus is parasympathetic, and the sympathetic part of the system, which does not have dilator control, but fights with the parasympathetic so that the sphincter is relaxed. And this is at the celiac plexus at the level between T5 to T10. So another thing to remember is that the symptom of pain, which is caused by esophagitis and GORD as well, is perceived by afferent sympathetic fibers. So now it is becoming more clear how the stomach parts are represented in the adult anatomy. So this is the esophagus, that's the cardia. This part is the fundus of the stomach, and behind that, alongside the greater curvature of the stomach, is the body of the stomach. And then at the angle of the lesser curve, where the vertical changes to horizontal, the incisura angularis, if you draw a straight line, then the part before that or proximal to that is the gastric antrum, and the part on the pyloric side is the pyloric antrum. So the gastric antrum is part of the body. Pyloric antrum is still part of the stomach, but it has the capacity to contract more tightly. And of course, this is the cardia, where it's extreme bunching up of the circular muscle fibers and the first part of the duodenum. Now, if you look at it more closely, this is exactly the level where the diaphragm is pierced by the esophagus. And so therefore underneath is the beginning of pylorus, and that pylorus is predominantly circular muscle fibers, but the outermost part of the muscular wall of the stomach is composed of longitudinal muscles. The middle part of the stomach is composed of circular muscle fibers, and the innermost part is composed of oblique muscle fibers. So there are three different types of longitudinal fibers. And of course, the fundus and the body consist or contain parietal cells and other cells as well. The rest of the body contains other cells, which we'll talk about. And so that is how the anatomy sort of looks at in the adult formed stomach. And so when the stomach single tube turns to the right-hand side, that's the development of the lesser curvature, the greater curvature. And it is at that time that the left vagus nerve, being on the left side, is now the anterior vagus, and behind is the posterior vagus. And of course, in the cut section that you would see if you would to make a cut, you would see the mucosa, which has been squeezed together with various kinds of bumps with pits in between. So if it is all one surface, then if you fill up the stomach, it will stretch out. And it is this, the region of the gastric pit, which has abundant mucosal protection from mucus, other structures, and which is also where the parietal cells exist and secrete acid and other things as well with it. So once again, if you are looking at the surface, then this is of course it's sort of columnar base. The surface is serosa as it starts from here, and then of course the long muscles, the circular muscles, the oblique muscles, and the submucosa where there are blood vessels and nerves, and the mucosa, which is lined by columnar epithelium. But the columnar epithelium also has parietal cells, also called oxyntic cells, which are linked to the production of G hormones or gastrin, or therefore hydrochloric acid. And of course, it also has other cells as well, such as chief cells, which secrete protective mucin. And then it also has enterochromaffin cells, which have the capacity to secrete various kinds of hormones, and we'll shortly talk about this. So all of that is therefore in a pit. And so all of that therefore forms the gastric gland. So let us look at how stomach produces acid. This is important because we've all heard about proton pump inhibitors, and we've also heard about histamine 2 receptor antagonist. So how do they work and what are these is explained best through a simplistic explanation. I'm no physiologist, but as a clinician, I will explain what I have learned. So the parietal or the oxyntic cells mainly are present in the fundus, but it can be present in other parts of the body of the stomach as well. So they produce hydrochloric acid. So how do they do that? In the parietal cells is also always present degree of water, H2O, and carbon dioxide, which is secreted there and is present through vascular methods. So H2O combines with CO2 under the influence of carbonic anhydrase and leads to carbonic acid, H2CO3. Remember that HCO3 is bicarbonate, H2CO3 is carbonic acid. So this is now present in the parietal cells in the resting state. And so in the resting state, if there's a need for the parietal cell to secrete hydrochloric acid, the first thing that happens is the hydrogen ion diffuses into the cavity of the stomach from the cells. So the cells lose hydrogen ion, which leaks into the stomach cavity, and it also is accompanied by bicarbonate. We'll explain further how. So the hydrogen ion is transported into the stomach lumen by hydrogen, potassium, adenosine triphosphatase ion pump. The other name of that is proton pump. So when the proton pump or the HKATP's pump works, the hydrogen from the parietal cell cytoplasm goes out, and the potassium from the outside goes in to the parietal cell. So now the hydrogen ion has gone already into the stomach cavity, which is in an unstable state. And the potassium needs to go inside and be bonded by something else. I've mentioned that bicarbonate, which is already present, is exchanged with chloride. So the chloride from the outside goes, beg your pardon, chloride from the inside goes outside and bicarbonate comes in. So when that happens, then of course the hydrogen ion is already in the stomach cavity, and chloride ion, which is monovalent, is also out in the lumen. So if you place both the positive and the negative elements inside in one place, there is bonding due to opposing charges. So the unstable hydrogen ion links with the leaked chloride ion and forms the hydrochloric acid. So there are many known triggers which stimulate the parietal cells to produce the hydrochloric acid through this hydrogen, potassium, adenosine triphosphatase ion pump or the proton pump. There are a few chemicals which are secreted in the intestine which slow the secretion of acid down. In other words, once the acid eventually reaches the small intestine, it leads to release of some other hormones and other enzymes and structures such as somatostatin, nitrous oxide, and dopamine, released from the enterochromaffin cells of the small intestine, which go back via blood and slow down the parietal cells. So as the hydrochloric acid reaches the small intestine, the production of acid diminishes. It's a negative loop. And so what can stimulate secretion of hydrochloric acid into the cavity of the stomach from the cells of the parietal cells? So the main stimulant is gastrin, also called the G cell, from the parietal cell region, and orexin, which is another hormone. So when there is a need and a stimulus, there is a higher level of gastrin and orexin. And then this also finds a hormone which is less active called ghrelin. So gastrin works through ghrelin and activates histamine from the enterochromaffin cells. And that then causes the histamine to increase the hydrochloric acid stimulation or production first. Going back again, remember that this is the enterochromaffin cell, and that's the region of the parietal cell, and that is where everything is leaked into, which is the cavity. So ghrelin, therefore, when the level of ghrelin is increased, the appetite is also increased. And there is another hormone called leptin, which opposes it. So ghrelin increases appetite and leptin reduces it. In bariatric terms, if you increase leptin, a person won't eat much. If you increase ghrelin, he will keep on eating. Other cells of the stomach which secrete enzymes and hormones are protease, which is also called the chief cells. As we've mentioned, they are in the body of the stomach and other parts as well. The job of that is to activate the inactive pepsinogen, which is also present there as well, to pepsin. And the activated protein breaking substance called pepsin breaks down protein from whatever source. And remember also that the parietal cell also secretes a glycoprotein called intrinsic factor. And this happens in the gastric fundus and body. So the intrinsic factor aids to absorption of something. But basically, what it does is that when the food reaches the small intestine, which is where cobalamin is, vitamin B12, which is the extrinsic factor, then the intrinsic factor encourages dietary absorption of vitamin B12 into the bloodstream. And this happens more towards the ileum, but also happens from the proximal small intestine as well. Other hormones of interest from the stomach is also lipase. So this lipase is present in the salivary secretions as well as in the gastric secretions, and it breaks up the fats or the triglyceride. And so what happens is, if you break up fat, there is foam produced. And this obviously leads further to making sure that it also reduces the size and the texture of the swallowed food. The acidic pH of the stomach encourages absorption of dietary iron from the stomach, as well as thyroxine, as well as calcium. Other absorption takes place in other places, but the process is initiated here. Through evolution, if you increase acid, gram-negative bacteria are killed. And this is why acidic pH is generally helpful for the bacteriostasis and bactericidal activities. We've mentioned that saliva secretes lipase, but it also secretes amylase. And that, of course, is more related to destroying or breaking up the starch. So reminding again, gastric glands secrete hydrochloric acid from the parietal cells, proteases as well, and this damages the bulky proteins. Pancreatic glands, which allow secretions to enter into the second part of duodenum, will add on to the swallowed food lipase, protease, and amylase. Another contribution that the small intestinal part of the enzymes and the hormones offer is that they secrete intestinal juice, which is a lot of mucus via the crypts of lubricant in the intestinal wall, as is the case with the gastric pits in the mucosa. And so the overall action of the acidity, lipase saponification, protein breakdown will be that the food which has already been pulped down due to the tri-layered muscles in various ways now becomes a chyme, which is creamy. Gastric body cells also secrete a mucus, the chemical nature of which is a protective layer in the lining. So this is where the H2 receptor antagonist comes into play. Chief cells are main cells which secrete various kinds of protective enzymes and pepsinogen. So it's a complex matter, surprisingly, all works well in a healthy person. Revising again, goblet cells secrete mucus to form a protective stomach lining. Parietal cells, oxyntic cells, secrete hydrochloric acid, maintain a low pH environment. Gastrin cells secrete gastrin, which stimulates release of stomach acid to increase stomach acidity. Resting pH of the stomach is 1.5, and it can go up to 2, but not more. It is this that is blocked by antacids and by raft alginates. Gastric is secreted in the gastric antrum mostly, and by the parietal cells of the fundus next, and from the rest of the body afterwards. So therefore, one can see that the chief output of acid is in the antrum, and then in the fundus, and in the body. Although the population of parietal cells is highest in the fundus, the secretory nature of it is more in the body. So at this acidic pH, which is optimum, and at resting level, hydrolysis occurs in the stomach enzymes. We talked briefly about the inhibitory enzymes. So the gastrointestinal system also has D cells, which is gastric delta cells, and they secrete somatostatin, and therefore it opposes or reduces the stomach acidity, and it also reduces the tone of the lower esophageal sphincter, so the food continues to go down. The chief cells secrete pepsinogen, which is a protective mucus. So whilst talking about this, we need to digress a little because we've already talked about intrinsic factor. Pernicious anemia happens due to reduced intrinsic factor, and the cause of that is due to weakening of the stomach lining, particularly in the area where oxyntic or parietal cells exist. Atrophic gastritis due to recurrent acidity, unopposed acidity, inflammatory nature, use of NSAID, or largely due to immunological condition. Autoimmune gastritis occurs when the body's immune system attacks the actual intrinsic factor protein or the cells, parietal cells which make it, thinking that these are enemies. And this is why atrophic gastritis and pernicious anemia, because of damage or inactivity or reduction of the intrinsic factor, is usually not seen until after the age of 30. Average age of diagnosis is 60, and there is positivity of family history and other endocrine disorders being present. So if intrinsic factor is reduced, probably there is reduction of parietal cell acidity also reduced. And so it's no wonder that as a result of these things, diarrhea, vomiting, or constipation and anorexia will take place, leading to fatigue, and then of course, postural hypotensive actions with minimal exertions. Possibly over a period of time, there would be macrocytic anemia, and therefore it would cause clinical evidence of anemia. There will be shortness of breath on exertion, heartburn, and other associated features are glossitis, pharyngitis, and also, of course, bleeding gums. So back again to GORD, what could stimulate parietal cells to be making more acid? And this is the revision. Smoking, alcohol, aspirin, stress, anxiety, family history of Zollinger-Ellison syndrome. So all of these would stimulate the parietal cells, stimulate acidity, and relax the the upper esophageal sphincter, and there would be reflux. Something which reduces the lower esophageal sphincter tone. And mainly, this is the upper esophageal sphincter tone. Caffeine, chocolates, obesity, pregnancy, tricyclic antidepressants, certain hormones like somatostatin, hiatus hernia, alpha blockers such as amlodipine and its brothers and sisters, anticholinergic medications such as buscopan, and beta blocker, calcium channel blocker. I beg your pardon, the alpha blockers would be doxazosine, and calcium channel blocker would be amlodipine. Bisphosphonate of any kind, steroids, NSAID, nitrates as are used for protection of angina, and some diuretic. So all these can reduce the lower esophageal sphincter tone, so the food can pass down, but mainly also the upper esophageal sphincter, so the food goes backwards. So what are the risk factors of Barrett's ulcer? Usually male chronic episodes, increasing frequency, past history of hiatus hernia, recurrent esophagitis, peptic ulcer, or fibrotic structure. So these are those factors which lead on to Barrett's ulcer, and we all know that Barrett's ulcer is very symptomatic and it could lead on to becoming a cancer of columnar epithelium lined ulcer, which has a worse prognosis, as we all know. So now we go back to the GORD. How often does one see it? In Western world, the incidence is between 10 to 30%. Italy has higher number, Greece has a higher number, UK and Norway have less. And the incidence is calculated in these Western regions as 5 in every 1,000 person per year. Internationally, where there is a stress of poverty, lack of vitamins and appropriate diet, insufficient diet, more infections, the worldwide prevalence is 13%. The prevalence of GORD increases with age. So the thing to remember in this is men have more severe esophagitis and women have more endoscopically negative symptomatic reflux disease. So how does one control gastric secretion? So we know that there is a neurological inbuilt control. So vision, smell, thought of food will lead immediately to increased secretion of gastrin and related substances to produce hyperchlorhydria. Similarly, when bolus enters the esophagus, then there is distension, stretching, firing off of electronic signals, and therefore it then leads to where the bolus is stretching the structure of the esophagus, the upper part remains tightly narrow and the lower part begins to relax. And this is how propulsion downstream takes place. The gastric secretion is also controlled by a feedback from the hormone or the enzymes. Reminding again, gastrin is secreted by blood vessels from the gastric pits, and it stimulates acid. If your stomach pH goes down less and less, that means it is more acidic. Then gastrin is inhibited by gut hormones, which is secretin and somatostatin. So when the chyme is in the duodenum releases digestive hormone, which is secretin, and cholecystokinin, which stimulates the pancreas, and therefore there is a reduction of carbonic acid, and liver also throws in bile to emulsify fat. Pancreatic juices contain bicarbonate, which reduces stomach acids, while the liver produces bile to emulsify fat. Common symptoms we have already discussed, and this is a question of quick revision. Post-cybal retroesternal burning, feeling of acid reflux and regurgitation unintentionally, dysphagia or sense of food stuck in the esophagus, esophagitis causing localized chest pains, worse at nights. Angina is worse on exertion, and esophagitis or reflux is worse on dependency when the head is level with the stomach. As a consequence of atrophic gastritis, atrophic esophagitis, atrophic pharyngitis, or rhinitis, there is halitosis, sore throat, hoarseness, and coughing, perhaps due to aspiration. Because of imbalance between the upper and the lower esophagus sphincters, there is bloating. Sometimes there is helpful physiological belching which takes place as in winding. Otherwise, it would produce by stretching features of nausea and vomiting. Symptomatically, we now categorize GORD as stage 1 when it is mild and feeling of acid reflux, and it happens once or twice every month, but can be self-managed. No need for seeking attention. Stage 2 is when daily requiring prescription and moderate symptoms. Stage 3 is severe condition, the activity of daily living is affected, and repeated GP visits are the order of the day. Stage 4, when there is possibility of Barrett's or suspected cancer with other conditions, such as hematemesis, beta symptoms, weight loss, symptoms of metastasis, and so on, or other features of autoimmune disorder. With such symptoms being so common, as I have said, that universally it is 13% that people have reflux esophagitis, it still is the case that only about 26% of patients who are symptomatically diagnosed as having or suffering from reflux esophagitis can be picked up at stage 1 and stage 2. So if you diagnose dyspepsia and treat patients with treatment suggestive of antacids or PPI or H2RA, then you would be actually correct only in respect of 26%. So what diagnoses it accurately as far as symptoms are concerned? And the gold standard is 24 hours pH monitoring. This is done through a capsule swallowed, which can be monitored, or through other forms of measurements. Now, if you diagnose GORD on the basis of there being histological evidence of conversion from squamous cell epithelium to columnar-like epithelium or inflammatory disorder, as in the case of sort of Barrett's esophagus, then one can histologically diagnose it as non-erosive reflux disease. There is no ulcer, no acute inflammation. Symptoms suggest reflux. Erosive esophagitis, when you actually physically see ulcers and acute inflammatory changes. Strong association of symptoms of acid hypersensitive esophagus. So you do not have abundant trigger, yet the symptoms are aggressive. So it's this category. Barrett's esophagus, we've already talked about. But there is a case of diagnosing, even in histological terms, functional heartburn. That means histology doesn't confirm erosion, ulcer, or acute inflammation. Other tests are normal, such as the pH does not suggest excessive acidity post-cybal or on lying down, yet the patient has heartburn. So this category is also included. So remember that the diagnostic features of GORD are that there are reflux symptoms occurring over several times a day, and these are characterized by feeling of reflux, which is regurgitation and heartburn. So what can go wrong with GORD if it is insufficiently treated or not treated? Esophagitis from the lower part of the esophagus, which is usually in the chest. The spread of esophagitis goes upwards proximally. Gradually, the chronic inflammatory change of fibrosis will take place, or even before then, the symptoms will cause aspiration, pneumonia, pharyngitis, halitosis, gum bleeding. In respect of untreated GORD, eventually culminating in Barrett's esophagus, this would happen after the initial suspicion minimally of Barrett's esophagus in 20 weeks. And further 20 weeks later, there is early onset of adenocarcinoma. So when someone suspects such a problem, what would be the differential diagnosis? Gastritis from any cause, peptic ulcer, gastric cancer, esophageal cancer, unremitting, unrelaxing spasm of the cardia, Barrett's esophagitis, histologically bad esophagitis with erosion, acute cholecystitis, and then autoimmune or eosinophilic esophagitis associated with other lesions. The commonest association is with scleroderma, pericarditis, and ischemic heart disease. So we are nearly at the last leg of the journey of this discussion. How is it treated? PPI, H2 receptor antagonist, antacids, alginates, and surgery. So briefly talking about antacids, calcium carbonate such as Malox, Mylanta, Riopan, Rolaids, and Tums would neutralize existing acidity as the antacid finds it, and then works almost immediately, and then about 15-20 minutes later, more acid is formed. So the given antacid is useless. Alginate is a kind of a raft. Raft means providing a coating to protect from harm. So this usually is found as an anionic polymer from the brown seaweed. It's a bacterial byproduct. And therefore, it then coats the gastric pits, just as the chief cells coat the gastric pits with mucus. The raft or the alginate coats it even more strongly and causes a barrier as a gel. And so when food is consumed, there is outpouring of secretions. So it is that which is not allowed to attack the gastric pits and the delicate mucosa. Common example is alginate Gaviscon. And the advantage is that if you were to take antacid, which works quickly but is short-lived, alginate works after half an hour, and it then, of course, stays on, causing benefits for a while longer. Surgery is in fundoplication on the assumptions that there's a greater population of parietal cells in the fundus. You reduce the fundus by bringing it close to the cardia, which is the lower esophageal sphincter, and wrapping the fundus all around it. So you have therefore ischemically reduced the population of parietal cells. Procedure is called Nissen's, can be done through open surgery or laparoscopically. Briefly, the PPI, which is the ideal treatment to use for reflux esophagitis, reminding again that the proton pump is this: hydrogen ion, potassium, adenosine triphosphatase ion pump. Other name is proton pump. And that the purpose of the proton pump is not talking about inhibitors, I'm talking about proton pumps. So proton pumps will allow hydrogen ion to leave the parietal cytoplasm and go into the cavity of the stomach. So hydrogen ion leaves the cell, goes into the cavity, and it at the same time, potassium ion from the cavity goes inside the parietal cell. So one positive ion goes out, the other positive ion goes in, but then it has to combine with the chloride ion as well. So if somehow you damage this pump, you are giving the patient proton pump inhibitor. And so there's a list which I'm sure you are fully familiar with, so I will not go down into detail. Omeprazole, lansoprazole, pantoprazole, riboprazole, and esomeprazole. So you can see the common doses that we all know about. And then what are the contraindications, adverse side effects, and drug interactions of PPI? So it does interact, and you must be careful if you know from the history a patient is on these kinds of medications. Notable are digoxin, SSRI, warfarin, anti-epileptic drugs, and then antiplatelet drugs. And in the light of COVID-19, if a patient is on these as well, antiviral agents. Histamine 2 receptor antagonist. Example of histamine 1, which prevents allergic reaction, that means wheel the increased inflammatory and edematous change suddenly produced, which is the H1 histamine 1. Example is levocetirizine. So it controls allergy. The example of histamine 2 blocker is ranitidine. So one thing to remember is that histamine 2 also potentiates H1, whilst it is useful to sort of say cut down on basal HCl. So ranitidine is delicensed in USA and now is not available, and the manufacturers don't make it because the additives to ranitidine were supposed to be carcinogenic. So what H2 receptor blockade occurs with ranitidine is that at the best of time, when someone has not eaten, the basal output of parietal cell acid is reduced. Also, when someone eats, gastrin, ghrelin, sort of related, histamine-related provoked HCl increase is also reduced. It's an inhibitor. So H2RA potentiates H1 blockade, as well as it also reduces stomach acid. So who should avoid H2 receptor antagonist? Obviously, basically someone who is on these, and also it is usually 50 plus, someone with chronic kidney disease and deranged liver functions. There are other alternatives to H2RA. So going back to ranitidine, we've talked about the dose, and it is said that uh, that Zantac additionally causes problems because of enzyme secretions. So we often say that this is due to NDMA, which increases, which is carcinogenic. So it is N-nitrosodimethylamide. I mentioned it because I have difficulty remembering this word. So the alternative to ranitidine was cimetidine. And cimetidine, it has many side effects, including joint pains, and it inhibits cytochrome P450. So it has different kind of problems which cause more side effects than benefits. So this has now been stopped as well. Although ranitidine is no longer made, cimetidine is not used by the first choice. It may still be in use in special circumstances. An alternative called Pepcid, which is famotidine, is much better. The side effects are dermatological and depression. Nizatidine, a newer agent, Axid, is similar to Zantac in its strength, but it should not be given with chronic kidney disease or when there is derangement of liver functions. This is the end now. So the entire purpose of managing GORD is to diagnose early, to give a leaflet or a booklet or signpost the patient to reducing triggers such as modifiable factors, and then there are of course other factors to watch out for as well. Leaflets should also teach about the early development of Barrett's esophagitis as well as cancer. And then of course the aim should be a regular follow-up via primary care. If histological diagnosis is made, then it is very frequently the case that further sort of say visual assessment is made by way of OGDs or indeed of pH monitoring. So I hope that I have not spent too many complicated words and have spoken in the way as I have understood it. And I'm sure that this will add further to your management of such patients. And therefore, I hope that this has gone down usefully in helping you to remember more frequently. And therefore, this is in my website as well. And by all means, it's freely available, and hope that you make benefit and use of this presentation. As a presentation, but without actually a verbal description, it is also present in the presentation part of my website. Thank you for spending this much time. I hope it's been useful to you. Thank you.